I will try in the next 45 minutes to explain a little bit the consequences of the new Surviving Sepsis campaign that you certainly read already many times or assisted many times to lectures on which they were discussed to our hospital's performance. And this seems a very trivial issue, but it isn't, because to implement the new version, the 2012 version of the guidelines, you have to change the hospital, and you have to change the way you work in the organization to improve the patient's outcome. I have, first of all, a declaration of real conflict of interest. Is that I am not an anesthesiologist, not an internist, not a surgeon, not a GP. I'm an intensivist. And being an intensivist, I will not present you a neutral vision of the Surviving Sepsis Guidelines. I will be very partial. And my vision is the vision of the intensivist, and that means that I don't need to explain to you that we see the patient as an whole, not piece by piece, that we are used to deal with organ system dysfunction and failures from almost all organs, and not one at a time. And I am used to work with teams, not tribes. So I give these three statements as granted, and I'm not saying you have to like it. This is the way I am. We can argue a little bit with other specialities. This is the way to go, but this is my view. So I will try to concentrate in the other aspects of the problem on sepsis and its treatment. As you know, we have been discussing sepsis for many, many years, especially since Roger Bone proposed first modern definition of sepsis, because you have definition of sepsis as old as the 19th century. Good ones, in fact. And no matter which definition you apply, you have more and more patients with sepsis. This is true, as Derek Angus and others demonstrate in the United States, where the increase in sepsis cases is greater than the increase in population. As you can see here by Greg Martin, no matter if you look at prevalence, that you look at incidence, sepsis is increasing. And the same is true in Europe. When we did the SOAP study some years ago, you could see that the number of patients with sepsis, severe sepsis, and septic shock altogether were more than half of the patients admitted to a general ICU. Not so different from what we demonstrate in SAPS 3, where you can see that a significant infection was very important in ICU admission. And when Jody and others convinced Jean-Louis to repeat the EPIC study many years after the first EPIC study, 18 years before, you can see that the number of infections were very high, no matter the place of the world where you look. In some countries, of course, we can discuss during hours if there are more infections in some countries than in others, but all over the world, severe infection, severe enough to require ICU admission is very, very frequent. And to that number, and this is admission, a little bit over 30% in EPIC-2 study, you can see that we had with nosocomial infection our part to this until we stabilize around 70%. And the only good news on this issue is that we don't know why. If it's these therapies, all this stuff we do to our patient, is if because we are more sensitive to patient safety. We don't know the reason for that. But since the early 80s, mortality from sepsis is going down. And this is true for almost all countries in the world. And this has nothing to do with Surviving Sepsis campaign. Remember, the Declaration of Barcelona, who started the process, was in 2002. And you can see this data from the United States, again from Greg Martin. You can see that since the 80s, mortality from sepsis, the number of cases go up, but mortality goes down. And the same is true in France. Gilles proved that quite easily. You have more cases, but you have the same number of, if not a little bit less, of deaths. And if you go down under to Australia, then the drop is not a small drop, it's a massive drop. Why? We don't know. Possibly a combination of factors, and for that we have to understand what is killing our patients with sepsis, and then, only then, we can design a strategy to allow us to decrease that mortality. And that was the rationale behind this revision of the Surviving Sepsis campaign. We know that infection is strongly related to outcome, as you can see here, both to ICU outcome and to hospital outcome. But we know also that this relationship is possibly mediated by the development of multiple organ dysfunction syndrome or multiple organ failure syndrome, whatever you want to call it. And you see that when a patient will increase the number of organ failures, the mortality will increase and reach almost 70%. And when you look at the data from SOFA-score that Jordi was mentioned, you can see that when you move from 0, that's the minimum amount of organ dysfunction, to the maximum, 24, you almost don't see survivors anymore. It's quite beautiful relationship. Of course, we know that this is not the end of the history, because it's not the number of organs who is important, also the number of days in which the patient keeps a certain degree of organ dysfunction, and we are not able to decrease the number of organs in failure. It's also important. So we try to design a system not to punish the bad ICUs. That would be very easy. And then, okay, you identified the bad guys, and then you close them. I am sure that my government will love such a system. You just identified people who had more risk-adjusted mortality in sepsis, and then you close these guys. But if you do that, you forget that next year, into next year's evaluation, these guys will be the bad guys, and then they will be cut also on the system. So after a few political cycles, you will finish without ICUs, because there are variability in the way we address these problems, and just closing the bad guys and identifying the bad guys is not a good way to deal with that, because there are no typical septical patients. So the best we can do is to find a way that allowing some variability, because not all patients are the same, will decrease the variability in care and provide to each patient a minimum pack that would allow the patient to have the best possibilities, the best probabilities to survive the septic episode. This is not new. This all started in this nice city with the Declaration of Barcelona in 2002, 2004, the first guidelines, the partnership with the Institute for Healthcare Improvement, then a lot of discussion around the Peter Eichaker editorial in New England Journal of Medicine, guidelines revision, first evaluation of what's coming out of the guidelines in 2010 from Barcelona too, and then revision in 2012 of the guidelines and of the bundles. And now this is to continue, and let's see in 4 years' time what future will take us. But just to start, I will base my talk mainly on 2012 recommendations that were published this year. I will not to put too much emphasis in some of the controversies that the surviving sepsis generated, just to say that for this revision, we were very, very strict on dealing with potential and real conflicts of interest, including non-financial but academic conflicts of interest. We used Grade Pro just to look at all drugs that have been proposed to treat sepsis, and from that large number to choose to pick up the few ones that could have a positive impact in our patients. What was not an easy task, and had to be done not only to pharmacological interventions, because when you think in the amount of things we do into OR, the amount of things a nurse has to do when dealing with a septic patient at the bedside during a nursing shift, it's quite difficult to write a manuscript with less than 1,000 pages that can summarize everything we must do to prevent complications, to treat sepsis, to improve patient outcome. And unless we say that, well, this is the magic bullet, this will treat everything, all types of sepsis, in all patients, in all parts of the world, this is not the aim of the guidelines. The guidelines have been designed to treat the common patient in the common ICU, in the common country. So, of course, we have to acknowledge that they were not designed to that special patient in the middle of the Amazons where dengue and malaria, co-infection with two, could be the major problem. They were designed for cities like Barcelona or like Lisbon. And again, and I reinforce this, with the aim of decreasing variability, not to be used as a checklist, as you have the surgery checklist, but a way to improve outcome. And to improve outcomes, you have to be quite small in the number of measures. If I give you to read something, let's say, the Apollo 11 manual that is free in the internet and is fantastic to read some parts, that has something that like 12 million pages. Okay, it could be the best guidelines in the world how to deal with that machine, but it will never be used in our emergency department or in our ICU. And we are very reluctant to change. And I will try to understand together with you why. This is the first work published. It was published in 2008 in JAMA by Ricard Ferrer and co-workers on the in the real world, based on 2008 guidelines, happened to put the outcome of a patient with severe sepsis or septic shock. And you can see that it looks nice. The P is below the magic number, is 0.01, so it's magical. And you can see that survival is greater in patients who were treated according to the bundles and the guidelines than to the people who were treated before that intervention. 2 years later on, Mitch Levy and co-workers published more or less something in a larger cohort, not just from Catalonia, but from all the countries. And this is the summary of the results. And I would like that you focus in 3 things in this slide. The first one is we have a positive result. After 1 year, so 4 quarters, after 1 year, you could see a significant difference in mortality. but going from 37, 38, not even so, to 30. So it's not really impressive. Second, compliance with the bundles increased, both for resuscitation bundle and management bundle, but increased from 10 to 30% at maximum. So even with a massive effort in all hospitals, in all emergency departments, in all ICUs, you could only change behavior by a very, very little thing. Why? Because the bundles were designed to apply some receipts to our patients, and our patients are not the same. And again, when we go to the EPIC study, and you split patients by the area of the world, you can see that, for example, the severity of the patients is quite different in different parts of the world. Mortality is quite different, going from 14% in North America to 10% in Oceania, but going to 27% in Brazil and Argentina. So we are clearly speaking about different patients. Of course, we can always draft charts like this. This is from SOAP, and it was very good for my country. You can see that we had one of the highest prevalences of infection, severe infection, on ICU admission, but we stay below the line of mortality. So we had a good performance for the amount of infection we had. And Spain is here, also in the down part of the curve. But we cannot apply some receipt to all patients, because in some places we just don't have the resources to do so, like in this case. On other places, the threats come from different zones. If I was living in Pittsburgh, I will be crying and running away when I see this on the news, that a thunderstorm is coming. In Lisbon, we never had, as far as I can remember, a severe thunderstorm. So each country has their own particularities. And of course, it's always better to take the guidelines, to adapt the guidelines to your reality that is different from the reality from other countries. So to take a Bayesian approach to the issue. But at some time, I have to say that is better for you than to have the guidelines than to have nothing. Unless you have a nurse close to you, very skilled to go to Google the symptoms of the patient, and in a few seconds to give you the magic answer for what you should do. And it's very difficult to find nurses with those skills nowadays in Portugal, at least. And population is really different. I looked at that with Eliezer not so long ago, based in a cohort of the EPIC-2 study. We compared Europe with Brazil. And it were two different worlds, nothing to compare. And even in some country, and this is data for Europe, you can see that over time, diseases changed. Some of us in this room were here already in the ICU in the late 80s when AIDS appeared on the ICU. It was unknown before that zone. You can see that some diseases almost disappear in the course of history. And this is true also for therapies. I don't believe that Professor Rello, in the next session about treatment of VAP, will anymore recommend or show you this type of treatment. While in some parts of Africa, they could still be used quite often. I remember it was a couple of months ago, I was in Santo, and I asked the guys in the emergency department, they don't have an ICU in the country. They just have the emergency department with 4 beds where you can put a patient on the ventilator. And I asked how they were treating community-acquired pneumonia. And they say, well, it depends on the last charge we received from the World Health Organization. It could be a macrolide, it could be doxycycline, it could be amoxiclav. It depends. When you open the container, you see what you are going to use in the next 3 months. So that was the written antibiotic policy on the country. So we cannot have the same approach in all the places. And also people in many countries, especially north of Europe, have, and in North America, have strict directives to stop therapy at a certain point, while especially in Southern Europe culture, we tend to keep the patient in the ICU, colonized with more and more resistant bugs until they die. And it's very interesting when you compare most of the epidemiologic studies such as SAPS, that time to survival, the length of stay in survivors, is more or less the same in most countries of Europe. But length of stay in non-survivors is almost 3 times longer in south of Europe than in the north of Europe. So we are not producing more survivings. We are just keeping our deaths in a limbo state for a couple more weeks and paying a huge price for that. And this explains possibly some of the differences why when Mitch Levy applied the Surviving Sepsis campaign in a single way, those 2 bundles, the 6 hours bundle and the 24 hours bundle in Europe and North America, you can see that difference as not so big, apart from lactate possibly in 2 sides of the Atlantic. That mortality was much greater in Europe. But when you adjust these to cofactors, so patient characteristics, you can see that mortality, risk-adjusted mortality and demographics-adjusted mortality was the same in Europe or in the United States. So we are just dealing with different patients, and we have to apply, to think, if we, from the physiological point of view, are not so different from North Americans, why there are so large difference in unadjusted data? And that sometimes there are huge differences in the way we expend money treating patients with sepsis and why this money we spend is going up very quickly. You are very lucky not to know yet this guy. We want to export him, but we cannot find any country who can receive him. He's our healthcare minister. And in the last years, all his policy has been to decrease the amount we spend, not to increase the amount of lives we save, but just to decrease the cost per death in the country. And when you think at the medical costs, we can see that we have been very, very effective in some issues, traffic injuries, occupational injuries, domestic injuries. That's true for males. For females is not true, maybe because they are not used to new generation to domestic labor, and so they have more and more domestic injuries, while for males that since many, many years have been used to home working, it was not so different. But no matter the country where you look, costs are going up. And this is a tragedy, because we are facing a disaster. Why? Because we live, and I will skip 2 or 3 slides, we live in a country that is quite unreliable. The reliability in which we deliver medicine to our patients is very low. This is the reliability of some common interventions. And think on the ICU. You had the IRDS network protocol about 5-6 mL per kilogram of predicted body weight, mechanical ventilation as tidal volume limit, demonstrated a couple of years ago that it decreased mortality. But in fact, when you see 7 years, so only 3 out of 7 patients were having the new therapy. And this was just a changing into ventilatory settings. Look at tidal volume. And this is data from SAPS data. And across other studies, some of them conducted from Spain. And you can see that over the years, okay, you can say there is a slight decrease here in 2004, 2005. But people did not change the behavior. And this is the same that we show at the beginning. We changed the concepts, we changed the guidelines 3 times already, and people did not change the behavior. The degree of compliance of the guidelines was low. It could be increased. It could be increased by a small amount, and it had some effect on mortality, but not a huge effect on mortality. So I think, and it was the sense, or the common sense of the group when we started to write this, that we have to put our small brains together to think that each well, that one disappeared, to think that each intervention can be linked to a problem. Of course, people have, and when I say people in this picture, are doctors and physicians, nurses, healthcare personnel, has to right to make their own choices, sometimes bad choices, but sometimes they pay a price. If you give total freedom to people to organize departments and to choose antibiotics and to choose intervention and to use starches and to ventilate patients with 10 ml kilogram, you are free to do that choices. But then you pay a huge price for that. Worse than that, your patients will pay that huge price for that wrong choices you make. So we have to take our very complex profession and think that, as Julian Bion highlighted, when this came from the Lancet on some issue where Mitch published the difference between Europe and the United States on guidelines. We have a systems issue, and this, I would say, is systems issue. And from here, I will go to the bundles. Our emergency departments, our way for the patients to reach the ICU was not designed to be fast. We take too long since the patient starts with the first symptoms of the disease to the decision in his mind or in his family mind that he or she will need medical care. And that is because we are failing on the public. We were very successful saying to everyone in Spain, in Portugal, in France, chest pain, acute myocardial infarction, rush to an ICU, rush to a coronary ICU. But we have been failing completely and let patients stay home, hypotensive, dry skin, dry mouth, fever, cough, and all the stuff you know. We have been very, very bad with public, and we have to change that. Otherwise, patients will always arrive late to the emergency department. And then in the emergency department, I don't know your emergency department, but this is my emergency department. You need a GPS, or at least 2 dogs, those used to guide blind people, to make your way through the system before you get your bed on the ICU. So I think the most important thing on the guidelines, in the new guidelines, is not the first recommendation that you should start treating hypertension with crystalloids, against the use of colloids, to give antibiotics very quickly. I think the first words of the first recommendation says it all. You have to triage all potential infected patients for the presence of sepsis and severe sepsis. And you have to link that to a system that fast-track those patients to a place where they can get better care. And I don't know a place where you can get better care with severe sepsis than an ICU. And so we looked at old patients on the old Surviving Sepsis database, and we designed the new bundles. We decided to drop the management bundle because part of his components are irrelevant. IPP, no significant change in compliance, high compliance at onset. Glucose, well, you can find papers saying everything about glucose control, strict or liberal. Steroids seems to work, sometimes yes, sometimes no, not in Surviving Sepsis Campaign database, and APC is not even on the market anymore. So we have to redesign this, and so we decided to start redesigning this with a clock, and to see if the patient receive all the therapy, all the interventions, pharmacological and non-pharmacological, that needs before 3 or 6 hours. So everything moved, the focus shift from the ICU to the emergency department. The emergency department is now key to evaluate your hospital based performance based on surviving sepsis measure. So it's not the ICU anymore, unless the ICU works very closely with the emergency department guys. So either you put your people, intensivists, people like you and me, in the emergency department, or you bring your expertise, you export your expertise to the emergency department, second option. Third, you create fast tracks for patients with suspected severe sepsis. And for that, you have to have less patients possibly in the emergency department, and tell emergency department physicians that they cannot process all patients in some way. There are no magic bullets. They have to see patients one per one and to adjust things one per one. And so this is the two more important package we could find out of the 29 recommendations. Measure a serum lactate within 3 hours of diagnosis. Obtain blood cultures prior to antibiotic administration, except if that delays the antibiotic administration, what should not be the case in any hospital in Western Europe or North America. Minimize time to administration of broad-spectrum antibiotics with a maximum of 3 hours. And this was a big discussion because Europe and the United States voted in completely different ways on this. All Europeans vote 1 hour. All Americans voted 6 hours. So after a 2 days meeting in Chicago to discuss that 2 lines, we agree to put 3 hours and then to add to the notes, if possible, try 1. Why? Because our American colleagues were very much afraid that if delay the antibiotic, let's say the patient goes to the ED and just get first shot of the antibiotic, let's say 3 hours after admission, and the guideline says 1 hour, they will go to court and they will have to pay a big fine. What would be a good thing? But of course, from the North American perspective, I can understand our colleagues to relax a little bit on time, because all the evidence in Sam and Kumar and others shows that 1 hour is better than 3 hours. So, but 3 hours is the maximum you can afford. It's not 3 hours after the patient be on your ICU. It's 3 hours after the diagnosis to come to the mind of some guy outside the ICU. And finally, in the event of hypotension and or lactate greater than 3, to deliver a minimum bolus of 30 milliliters per kilogram of crystalloid within 1 hour. Second bundle that summarizes the second part of the guidelines is to be completed within 6 hours. Again, in my country, half of these patients will be outside of the ICU yet. To apply vasopressors if the patient remains hypotensive and not respond to initial food resuscitation. If the patient maintains hypotension despite food resuscitation, start a central line, achieve a certain central venous pressure and a certain oxygen saturation. Not because we believe that these are magic goals, but because this is reverse protocol, and there are 3 ongoing studies trying to show that saturation is not so good, but until one of them or 3 of them are published, it will be very difficult to say that Rivers and North Chicago population are different from our patients. So the goals are the same. But think on the implications of these goals. You have to be, if I want to judge your performance, and this was a challenge from Jody when he chose the title of this session, if you want to base your performance evaluation on the compliance with measures, you have to plan a new way for intensive care physicians to take their expertise as close as possible to where the patients arrive to the hospital. And that means the ED. And in some settings, not even the ED, the pre-hospital system. And these, we have to redesign our system. We cannot stay working in one side and the emergency department working in other side. We have to put our knowledge together. We have to work as a team, and we have to look more at processes, why the antibiotic was not given, than just why it was given at a certain time, why it was not given together with blood cultures. We have to think in all this process and optimize these processes, especially because this is data from an editorial from Henry and Niall Ferguson a couple of years ago when we performed SOAP. It was very interesting because when I measure your risk-adjusted sepsis mortality, the line is similar to your risk-adjusted performance for other diseases. The implication of this is that if you are good or better than the reference population at addressing patients with sepsis, you will be better than others at treating patients, addressing patients, managing patients with other diseases. And this relies all in process measures more than in outcome measures. And for that, we need an interdisciplinary team, something that a few years ago, this is from 2006, I already had white beer, but not as much as today. We put a lot of emphasis together with North Americans that we have to shift, as Mitch Levy and the editorial accomplished. We have to shift our interventions from the outcome, in this case, did you give the antibiotic to the patient, to the process, at what time and how long after ICU admission you give the right antibiotic to the patient, because this makes the difference. It's not just the patient to receive the antibiotic, it's to receive it on time and the right antibiotic, not just an antibiotic. Now we are, and I will finish in 5 minutes, we are changing our paradigms. We are well ahead of the past. We don't know what the future brings with it. We hope good things. So don't read newspapers, don't watch TV. But we have to trust. And I trust since I was almost a kid. When I started to practice intensive care medicine, I will not tell you when, because half of that room was not born at that time, apart from Jody and a few other faces in the group. But we have a strong speciality. We have a speciality with feet on the ground, with big figures in the past like Ibsen, Govsky, Safar. We could evolve from the concepts of reanimation to intensive care medicine. And now what we call intensive care medicine has nothing to do with reanimation, has poor to do with Florence Nightingale was telling 1 century ago about intensive monitoring of high-risk patients in a certain place. It is a little bit like Bill Knaus, one of the most clever intensivists ever, once wrote, "The human resources and the organization make the ICU, not the good drugs, not the good devices, but the consistency on the application by good people in a good organization of the things we think work." Remember that when our specialty was created, the diseases that make our specialty disappeared. Possibly none of you saw an acute case of polio. Now mortality from tetanus approach 0. We still see a few cases a year, but mortality is close to 0. Guillain-Barré syndrome, mortality is not 0, but is 1% or something like that. Acute organophosphate poisoning almost disappeared from Portugal, Spain. But these were the diseases who created our specialty. Now, what is killing our patients? It's very easy. We are ventilating in Europe close to 1 to 1.5 million people due to non-anesthetic reasons, so to acute lung injury. We have something like 85,000 cases of acute respiratory distress syndrome, and we have between 1 and 1.5 or 1.4 millions of cases of sepsis a year. So these are the diseases that now maintain our specialty. So we have to think in all these challenges that mainly I was here trying not to teach you or to advise you on giving a certain drug or using a certain device, but in changing your organization. Export your knowledge to other settings. Of course, we will have to train more intensivists to do so. What is very difficult to tell to our administration and to tell to our Prime Minister when the crisis is the crisis. But the alternative, and Derek Angus showed that almost 12 years ago, is for us to retire at 77 years. I don't know if Artur Mas already started to think about that in Catalonia. I am sure that my Prime Minister already has that slide somewhere in his package. Because the intensive care requirements will increase in the next years and will increase massively. And as I told you before, intensive care is not about machines. We can always buy machines if we have money. It's about people, and people takes time to train. It's about organization. And we usually give organization to peer that is unable to be on clinical duties. They are too stupid, too old, too out of the mood of the hospital. So we give them the managerial places. And we cannot continue to do so. We have to bring intensive care medicine to where it belongs, to people, patients and professionals. And when you can see the differences in Europe, I don't believe, maybe because I sit on, because I sit at an extreme, 4.2 intensive care beds per 100,000 million inhabitants. I cannot believe that a German is 7 times more sick than a Portuguese. I don't believe that. Data is data, and you have to respect the data, but I don't believe that is the explanation. You can see here Spain, you are in the middle. So 9.7 is not bad. But this means that I or my government is denying intensive care to a lot of Portuguese that need it. And is these organizational problems who delay the treatment and makes mortality to look bad, because this has a price in lives and is not explained. Most funny thing about this is that this is not explaining by the number of acute care beds you have, not by the percentage of your gross income you are expending in healthcare, or the percentage of your gross income you are expending in intensive care. there is no relationship at all. You can see a completely flat line. It's the way you organize your care. And so I think the only way to change the organization is for us to intensivists to open the doors of our ICUs and come out of our holes and start fighting. And if you want to fight for our patients, I can quote these guys. Why are we fighting? I don't know. Who cares? I think we were winning. And I think we have to see development as a mortality. The most important factor to decrease the mortality of a patient with sepsis is not a drug. Peter Pronovost proved it many years ago. It's the presence of an intensivist close to the patient 24 hours a day, 7 days a week. Of course, we assume that that intensivist knows all the surviving sepsis revision, has everything on his mind. And we have a nice profession, and we do it not because we are very well paid, because we have lots of free time. At least it's not the case in Lisbon. I believe it's not the case in Barcelona too. But we do it because we believe in what we do. It's what matters to us, to see a mother to take the child back home healthy, to give the wife to the husband, the child to the father. And that is what makes us. If we have to get out of the ICUs to start this fight and to start fighting with the administrations, let's do it. Don't be afraid. If we have to fight for our patients' rights, for them to receive 2 bundles on time, and for that we have to destroy the hospital structure, let's do it. And don't tell me bullshit about stressed intensivists. I never saw one. I saw a lot of stressed internists, a lot of stressed surgeons, a lot of stressed anesthesiologists. But just to finish, never doubt that a small group of truthful, committed citizens can change the world. Indeed, it's the only thing that ever has. Margaret Mead explained it all. It's our time to get out of the ICUs and start this fighting, to apply these things at the bedside. Thank you very much.